on the whole microphone, or do you just?
Oh, yeah, right. Good, thank you. Okay. Today we're going to talk about skin and soft tissue infections. I'm not going to talk about diabetic. I'm going to talk about osteomyelitis and diabetic foot infections. We'll exclude that. Okay. So the approach to skin and soft tissue infections is first to define the anatomy, guess and then confirm the microbiology, and recognize the clinical concept. So it's important that I want to get in the front lights as that possible. So to review the microbiology, the anatomy. The dermis and the subcutaneous fat. So impetigo involves the most superficial level of the cornea. Erysipelas goes a little bit deeper, but again is limited to the epidermis. Cellulitis extends to the dermis. And then necrotizing fasciitis goes to the deeper level of fascia. Then importantly, we get folliculitis, which involve hair follicles. Major microbiology, skin and soft tissue infections, staph and strep, but there are other exceptions. Streptococcus staph and great clusters. So in general, most of our skin and soft tissue infections are hemolytic streptococcus, mainly group A, but also beta hemolytic group B, C, G, which may or may not be beta hemolytic. Or staph aureus, methicillin-resistant, or community-acquired methicillin-resistant. And there's a subtle difference between PA, MRSA, and one of these infections we will go over. Otherwise, there are a variety of other pathogens that can cause skin and soft tissue infections. Pseudomonas and Ehrmonas occur with what exposure especially? What kind of exposure with a soft tissue infection would give you a Pseudomonas or Ehrmonas infection? A water exposure. Pasteurella maltata. Cat bites, animal bites in general, mostly felines, but also dogs have pasteurella in their mouth. Capnocytophaga, and in the specific syndrome of capnocytophaga, there's one host that gets fulminant septicemia from the captain. Anybody know what that host is? So this is one of the few fulminant sepsis syndromes, including things like falciparum malaria, Neisseria meningitis, fulminant sepsis, or capnocytophaga in the asplenic patient. So a person without a spleen who gets bit by a dog, we get a little bit concerned about this possibility. It's rare, but it's well described. These organisms, so a bite from a human mouth especially, and these are anaerobes, right? And Vibrio vulnificus, when might we get an infection with that? So hurricane survivors are characteristically people that get in trouble with that. So we're going to go through the different syndromes. As you remember, impetigo is the most superficial layer of infection. It tends to involve sun or the face or other sun-exposed skin. It involves the most superficial layer, the stratum corneum, and it's either staph or strep. It can be precipitated by trauma, insect bites, local trauma, or just colonization of staph on the skin. And it's usually don't even do systemic therapy. There are important differentials to consider. Herpes radialis is one possibility, and we'll go over the differences. And angular sclerosis. What is infection is associated with angular sclerosis? One? No, not that I know of. So this is a manifestation of thrush, believe it or not. When you have a breakdown at the and we'll show it can be a manifestation of thrush. So clinical clues are that this tends to be itchy, can be a very thick, sort of exudative, honeycomb exudate, and that's characteristic in children with impetigo, especially with staph. So here's some examples with this, often involving the face, a little bit of a honeycomb in here. This almost looks a little pustular, I would say, but it's not. It's more of this sort of exudative process. It's not to be confused with bullous impetigo, which is completely different skin syndrome that occurs especially in neonates. It's also toxin-mediated. It's a serious illness causes total body desquamation. That's an example. So the next level is folliculitis. The next important area is folliculitis, which is very superficial, again, starting at the hair follicles. Again, staph aureus is the most common, but we can occasionally see it with Pseudomonas and Canada. Anybody know what the setting of staph of Pseudomonas folliculitis is most commonly described? So there's some breaks at the follicles, and it's localized around the follicles. The different types include scabies and eosinophilic folliculitis. Who takes eosinophilic folliculitis? Pardon? HIV, exactly. It's not restricted to HIV, but it is more common than HIV. And besides the skin rash, what might an eosinophil, what laboratory test might identify a person with eosinophilic folliculitis? They have systemic eosinophilic. So this is itching, there's often crusting, and it's recurrent. Here, Pseudomonas folliculitis in women who was in a hot tub. You can see the distribution. This is a more typical folliculitis. So it tends to be pustular, discretely pustular, chronic, and ulcerative. It's pruritic, and as far as I'm concerned, that's a non-dermatologic, any itchy dermatitis folliculitis. Now, I'm right most of the time. We're making that diagnosis based on those criteria, but not always. Now, Candida can occasionally cause folliculitis. Here you see an intertriginous rash, and then you have these nice follicular folliculitis. Also involved in staph. It could be Candida. It could be either. You really can't tell the difference. So, sometimes if you have to treat for both bacterial and fungal. Again, with pardon me, tyrosine is a good choice. topical clindamycin works quite well. And oftentimes, unlike impetigo, you can rely on systemic therapy. Oral antibiotics or something like doxycycline or another anti-staph drug may be necessary. Now this is the difference between the distribution. So both are pruritic. Scabies is intensive, and the distribution of scabies can be similar involving axilla or extremities, but also the genitals and the hands, especially between the fingers. But the rash is indistinguishable, although here you can see it's a little more confluent and there can be tunneling. And to establish the diagnosis of scabies, you're supposed to do a skin scraping where you can see the organ. They do that in dermatology. You don't do that in anatomy, to my knowledge. Scabies also the risk of bacterial superinfection. So a person that gets scabies are at increased risk of and staph infection. The next infection is druncal, carbuncle, and pyoderma. So these typically, so you start with folliculitis, and then in the case of staph, you get a microabscess, a solitary small abscess, usually within a few centimeters, less than 1 centimeter, and if they coalesce, it's called carbuncle. Now those are usually in the staph aureus, and it's distinct from pyoderma, which is associated with streptococcus. Pyoderma is like de novo in an area of injured skin, say an insect bite, maceration. Pyoderma is much more common in settings of poor hygiene. In people that don't have access to clean water and in temperate climates, tropical climates. So this is a disease, especially of children, especially in poor countries. Strep, while these, in the vernacular of the Texas Eastern Tennessee, they call this boils or rising. It involves the extremities or the face. It extends to the subcutaneous fat. So as you saw with the hair follicle, it tends to be deeper. So it extends down along the hair follicle and can get deeper colonization, especially staph colonization. And as I mentioned, with scabies, then they get colonized with both staph or strep, and that sets them up for this infectious process. And then again, the treatment here is usually low topical. There can be topical or systemic carbuncle. Basically, you have to INC it. So these are, again, frequent, but also painful and all treated. So a furuncle in the nose is a commonplace. Painful, and it's a local, discrete microabscess, if you will. This is a complex abscess that will require IND, again, starting with a folliculitis. And here you see generalized, here extension of, you have crusting, which is probably starting as a folliculitis, extending with the carbuncle, and also cellulitis. So you have an extension now into the dermis. And the important thing is that you have an abscess measured usually more than 3 centimeters that need IND. So moving on to we have syphilis, which does not extend to the dermis. It remains in the epidermis layer. This is superficial. Because of this is the base strap or other beta hemolytic strap. It typically involves the phase and the lower extremity, usually the medial thighs. It involves the epidermis, as I said, and it blocks off lymphatics, so there is a lot of edema. And the characteristic is that it's quite painful erythema with edema that has a sharp demarcation. So whenever you see a very discrete level of edema with a sharp demarcation, the classic presentation is on the That's almost always root-based strap. And although I haven't looked at lately, that you can use topical therapy for this. Very often we need systemic therapy. So this is the classic erysipelas with a very sharp area of demarcation. You can't always tell if this is an allergic action. With an allergy, you will have the symmetric erythema and swell. The difference might be that you can see the sharp demarcation with erysipelas, severe allergic reaction. That's not always reliable. And then the other possibility is this is a pigmentation for discoid lupus. So finally, getting to cellulitis, and now as we talked about, this goes to the dermis, and we break it down as purulent versus non-purulent. So the purulent variants of skin infections so far are the folliculitis and the carbuncles and the abscesses, which is again a variant of a purulent skin infection. But when it gets to cellulitis involving the dermis, that is more important. So purulence just means and off the dermis. Classically, non-purulent cellulitis is predominantly, or other examples, classically, a woman who's had a mastectomy, who's had axillary dissection and impaired drainage, is at risk for a upper extremity cellulitis. It also can from any type of injury, including periorbital, perianal, or after infection. The main pathogens are group A strep for the non-purulent and staph aureus for the purulent, but also mixed gram negatives according to the setting. Again, impaired drainage is a risk factor. These usually require, they always require systemic antibiotics, often require to get adequate levels. So painful erythema and edema, and the distinction between purulent and non-purulent. So here's a classic example of a lower extremity cellulitis. It begins with entry of bacteria from toes up the lower extremity, either above the ankle or extending below the ankle with a tremendous amount of edema and pain. And here you see a bullous by virtue of edema. And the bullous is a very important finding. And the question that you have to ask, is this superficial bullous as a result of edema, or is this representing deeper tissue necrosis? Again, there's breakdown in the skin either from maceration or the bacterial infection, the infection. Always pay attention to the toes, and people that have recurrent cellular, actually, anyone with recurrent cellulitis, I think it's a fungal cream, and I ask them to use moisturizer on their feet regularly because almost always dry skin, sometimes with tinea. And the important distinction, strep cellulitis is important in and of itself, and of health consequences. But major issues to distinguish and identify those people with necrotizing fasciitis, where again it's extending to the deep fascia. Classically, it can occur just about anywhere, especially in the extremities, often in the lower extremities. Now, there are many pathogens that go through that in a minute, but the most important is the beta. Other beta hemolytics include the B strep and the community-acquired MSSA. For some reason, that should be community-acquired MRSA, has been associated with necrotizing fasciitis. Staph aureus typically is not an organism otherwise associated with necrotizing fasciitis. The so-called type 2, although that the biting cells would do this organism is called Clostridium sordelli. Anybody know what setting? So this is seen in women after childbirth or after an oral abortion-creating drugs. What's the name of those drugs? They take it, and for some reason, they are at risk for vaginal necrotizing fasciitis or perianal extending from the vagina and the perianal. In general, this is associated with diabetes as the leading predisposing factor, but some people will have no predisposing factor. And this is something that has to be recognized and operated on urgently, measured in hours. To recognize the syndrome, how do you recognize the syndrome? First of all, in distinction from a person with pain and a lot of edema, this person is septic. So that is, they have blood pressure instability, they often have renal insufficiency, and they have acidosis. So they have also extreme leukocytosis, we're getting 15,000. And in general, when you treat a typical group A strep cellulitis, over the first 24 hours, it will get worse before it gets better. So necrotizing fasciitis tends to be more rapidly progressive. There often is pain what you would expect. But we treat people with cellulitis. Very often pain is a very common feature. So this can be difficult. And then there's classically general anesthesia. That is, they have generalized pain, but in the area of erythema, in part of the area, towards the center of the erythema, they don't have any sensation. I don't know how helpful that is clinically. These are difficult diagnoses, and most importantly, bullous formation. You want to, if you see bullous formation, you want to use necrosis, and you need to get surgery involved. It could be superficial because generalized disease, but you consider that possibility. And this is an example of bullous formation that looks, in this case, relatively benign. There isn't much surrounding cellulitis. There isn't any indirect. There is generalized cellulitis. Excuse me. But there is not any surrounding necrosis. You could have formation, but this is a manifestation of deep-seated necrotizing fasciitis. We just had a case Sarah was involved with that case of a person with bullous just like this in the upper extremity, whose pain, he had no pain. He had been admitted with upper extremity edema. He had new formation of bullous approximately 24 hours after being admitted, and he had group A strep in blood. And the fact is that all of these necrotizing fasciitis are unique and very challenging. So the most important thing is to get surgery involved. There is no diagnostic X-ray like MRI that will reliably distinguish that. Oftentimes the surgeons will request it, and that's good. So we know that the fasciitis is basically have a high clinical suspicion, and then they go in and do a fasciotomy and explore the fascia to see if there's a problem. So this is an example. This could look like any cellulitis, in this case with a central ulceration and necrosis, making you think something deeper, and this person is, I mean, you can't tell just by looking at that is characteristic of necrotizing fasciitis or not. You have to take the clinical context into account. So these are some pain seems to be a consistent feature. The bullous formation, as I said, there can be necrosis like in the previous slide around that. Gas in the soft tissue is not seen with fasciitis, so-called type 2, and I'll go over that in the next slide. But with mixed necrotizing infection involving anaerobes or gram-negatives. Edema is prominent, but that's true with cellulitis in general. Most importantly, I think, is systemic toxicity. So cellulitis are in pain, but they're not toxic looking. And they might have high fever, but their blood pressure is good, their kidney function is good, assuming they have, or they're not. So those are really critical if you see that. If you see any of the systemic toxicity, you worry about that. And then the rapid spread. Over the first 24 hours, you're allowed to get a little worse, but after that, it should recede. And if it continues spreading, of course, it might be later than you hope. But again, you get surgery involved. So the type, this is really the type 2 strep pyogenes associated, which usually causes fasciitis by and other types of fasciitis involving Enterobacteriaceae and anaerobes. It may or may not be as, and these have different names, so-called progressive bacteriosynergistic gangrene, which is classically associated with abdominal wounds. Fournier's gangrene, which is necrotizing. So these are necrotizing processes that mandate surgery, but have different bacteriologies than the group A strep. There are several other necrotizing skin infections that are worth mentioning. Most importantly, eczema gangrenosum, and this is again the necrotizing process. This is actually a vasculitis. There is neutropenia as an individual risk factor, and the bacteriology is usually what? Pseudomonas is the most common. Other gram-negatives can do that. And then we're going to leave gangrene out. That's really part of diabetic foot infection, and we'll talk about that separately. But certainly people can have necrosing skin lesions due to gangrene, usually from ulcers and finally the syndrome of gas gangrene due to Clostridium myomycosis. Fortunately, this is extremely rare, and this is caused by a species of Clostridium, which is devastating, and it's a low fascia involving the muscle. It requires extensive debridement, occurs spontaneously, often involving the upper extremities and the chest wall. So this is actually a case of eczema gangrenosum that I took off the internet. This is a young woman with acute myelogenous leukemia with a progression aggressive, ultimately the process, and then with antibiotics. So we just had a diagnosis last month in a diabetic, which is, it's not really been described classically in diabetes, where the presentation was initially you'll see a lot of bullous lesions. And there's an example of a bullous lesion. Is simply defined as an necrotizing infection in the perineum. And this is an example. I've never seen Clostridium myonocrosis. I don't know if anybody has. I'm thankful that I've never seen it. But again, here you see tissue involvement with air, extensive air involvement. Again, superficial bullous formation. So this is sort of a summary slide in managing people with skin and soft tissue infections. They break it down. This is according to the IDSA guidelines. They break it down into non-purulent and purulent. And let's just start off, go through here. In cases of severe non-purulent cellulitis, which would include necrotizing infections, ordinary cellulitis, or erysipelas. Again, the most common pathogen here is group A strep. If it's severe, i.e. systemic toxicity, then recommend covering for methicillin-resistant staph and broadly with pip-kazole. Now, we do this for just about everybody, but they only recommend, and we're not the only ones, but they recommend that we reserve Vanco and pip-kazole for cases of severe non-purulent cellulitis. And severity is really defined by sepsis. And you look through the treatment, you decide it's a neck infection, then the recommended drug is a penicillin, the clindamycin inhibits ribosomal protein formation, and it's thought to reduce toxic inflammation by the base. Nevertheless, that's the traditional regimen that we use, or you can use another active drug like sulbactam, pip-kazole, ceftriaxone. And then there are other options. For the moderate or mild cellulitis, non-purulent cellulitis, the list of options include these, and again, note that they don't include pip-kazole and Vanco. And then for the purulent cellulitis, again, we're talking about the more superficial processes or the abscesses of furuncles, carbuncles, or abscess T, if whether IND is necessary. And then you can treat many of these antibiotics in the cases of carbuncles or abscesses. There was some controversy as to whether IND is the primary and only therapy or whether antibiotics actually. And it's pretty clear that antibiotics are beneficial in reducing the recurrence and improving resolution over IND alone. But IND is your main intervention. And then you can use, depending on how much associated cellulitis there is, you can use oral antibiotics, or you may require intravenous antibiotics where you're targeting especially staph aureus. So there are a lot of other pathogens associated with animal bites, cats and dogs, and there are rat bite associated. These are spirochetal organisms. Francisella tularemia, which is, you can get an ulcerative lesion on the extremities with an infected mammal. That would be a diseased deer, or usually this is seen in hunters who, for some reason, are butchering an animal that happens to have this illness. And bacillus is when you get spores from sheep that have the bacillus on a wolf, and this is I believe they call it. And then there are a number of fish-associated pathogens and virus-associated pathogens. The Mycobacterium marinum is seen in association with what kind of exposure? Pardon? Yeah, so usually but it can occur, I guess, with exposure to fish as well, direct exposure. Okay, and then I'm just going to finish with a couple of other things. So impetigo this could look like impetigo. This is herpes. The difference is, and you can't distinguish it necessarily on clinical grounds. Buccal mucosa. So if you have the lip, or certainly the inner buccal mucosa with extension, and that's most likely herpes. While impetigo will spare the lips. You can't really always tell that, but it is probably useful. Certainly when you clearly have lip involvement, you can herpes. And then you know that shingles, I guess that could look like folliculitis, but you can usually tell from shingles because there's usually plaque-like erythema, and most people are not seen as much anymore. And again, plaque-like induration, and this really gets into dermatology. But molluscum can be mistaken for herpetic lesions or face. So final, one of the important things with infection, especially with folliculitis and purulent can have recurrent folliculitis, literally every month, and it's devastating and very difficult for the patients. And that's because they're colonized with staph in their axilla, nares, or fluent. So anyone with staph folliculitis or any other, in my opinion, any serious staph infection should be counseled in terms of sharing personal hygiene items, razors, brushes, towels, and then decolonize, especially people with recurrent episodes of folliculitis. And this is a common problem. So by comparison in areas, we also ask them to put it in the axilla and the groin twice a day for a week, along with Hibiclens soap, which they're to bathe daily with it, from head to toe, along with an anti-staph systemic agent like Bactrim, or doxycycline, or minocycline. And this really, plus or minus rifampicin. And this is really necessary to break the chain in people with recurrent folliculitis. Or your staph infection, then finally I'm just going to go through the key drugs for myosomal, ceftriaxone, and cefepime all have extraordinarily good activity against disease-based strep, or most of the strep. Virtually all the strep are sensitive to this, except for Enterococcus, which is no longer a strep, and some other and rare strains of strep that have penicillin resistance. Occasionally, you see strep does. Streptococcus usually is not sensitive or has less sensitivity. These are your key drugs. Methicillin has a little less activity. These are your supreme drugs here. And then you can use these drugs in settings where there's allergy or you're considering other coverage for different reasons. Vancomycin you're going to use only if you have a person generally who is intolerant or allergic to the beta-lactams or penicillin, and clindamycin has decent activity against strep as well. For the staph, really our drug of choice is or cefazolin. And it turns out cefazolin may be a little superior to nafcillin. People with serious illness, cefazolin does a bit better. Although cefazolin does not get into the CNS, so if you're concerned about CNS penetration, you can rely on nafcillin-sensitive staph. Ceftriaxone has very good activity against MSSA, but you don't have a lot of experience with bacteremia, so we don't rely on this in a bacteremia patient. Cefepime also. And then again, the carbapenems all have excellent activity against MSSA. Again, Vanco and Clinda is good most of the time. But for RSA, Vanco is our drug of choice, then we're rely on these when we that is MIC greater than 2. So in people with serious MRSA infections, if you want to check a MIC to vancomycin, and actually greater than 1 is borderline, greater than 2 is what's called a vanco insensitive strain, and we're going to rely on these others. It turns out that people that have resistance to vanco often have resistance to dapto as well. Ceftaroline is used in the nasal. Gabapentin and ribapentin are long-acting drugs that are used mainly for skin and soft tissue infections. And then you know about the oral drugs, Bactrim, Kindred, and Zoxy for the superficial infections. And we have all of these infections. Any questions? Yeah, and that's tough. But what we're learning with duration is that shorter is better. And, 10 days, and this is just purely experience on my part, and there isn't, I don't remember what the guidelines were. I think it's double checking that.
In patients with lymphedema, do you like it? Do you carry them with the IV, or you?
Yeah, so my approach with cellulitis is, and that requires intravenous, is I treat with intravenous until the cellulitis is gone. And that usually takes about 5 to 6 days. And then beyond that, we usually give a course of oral antibiotics that is probably the cell.
So it's my first day last week with a patient that had pulmonary and liver sarcoid, and this was his third time presenting with cellulitis, recurrent cellulitis in the lower extremity. And we ended up getting the urine wall, and we ended up working it out, and it turned out to be the patient with sarcoid also.
Really?
Yeah, it was a super infection. For a patient like this, would you consider he has to go back on to immunomodulators. Do you consider putting him on
most of them have significant lymphedema problems. And in those cases, there are a handful of people that I'm following and are admitted literally every people have been shown that prophylactic or continuous antibiotics is effective. And so I have them on twice a day, usually a penicillin. And the studies that have shown improvement have only lasted for a year. But I keep them indefinitely. One person in particular is losing weight and is going for bariatric surgery. So we have an endpoint. Once his weight and edema improves, then we're going to try to stop. Oftentimes they require a indefinite course of twice a day antibiotics. Then what's your experience? Have you had anything like that?
Yeah, so of all the species in the world,
Okay, thank you. So I think the important thing is that, I think that when we need to distinguish this from diabetic foot infections, because most of our skin infections occur, but in general, if you have a non-diabetic or a diabetic that does not have an ulcer, please avoid the temptation of just going to potato. Be confident in the stress. If it's non-purulent and they're not septic, a good streptococcal drug is I could even live with that. If there's pus, if there's purulence, for MRSA. The problem with potato and vanco combination is we're learning it's nephrotoxic. So we're expecting continues of these So be confident about this coverage to start out with.
Thank you.